Broussard.
That's fine. Thank you, everyone. It's a pleasure to meet all of y'all. Y'all have given me a very warm welcome here so far in Mountain Home. I'm very happy to be here, and I've really enjoyed my stay for the last 8 weeks. So, Dr. C, I just have one question for you. What came first, the marijuana or the mental disease?
It's a little bit like a chicken and an egg.
Exactly. Who knows? All right. Another interesting statistic is that more medical students and physicians transfer between psychiatry and surgery and psychiatry than any other specialties. Let that sink in. All right. So Ron tasked me with coming to Baxter to help develop and to recruit and build a full-service vascular department. And I'm very happy to be here, and he needed somebody with a little bit of gray hair to help mentor some young folk. And we do have another gentleman coming in August by the name of Dr. Arita. So we're building the system. He also asked me, to add some procedures here so that patients don't have to leave the community as often. And then the third thing was to give Dr. Noctegal a little bit of a break. He's been working pretty hard. So I'm not going to give you any statistics or anything today. I'm just going to give you the, hey, look what I can do talk, which I typically hate doing, but everybody always asks, well, what is it that you do? So I'm gonna tell you. So I've been in practice, as he said, for 25 years in Jackson, and most vascular surgeons love doing big open vascular procedures. They really are cool. They're fun for the surgeon. They are not fun for the patient. And as the population ages, I mean, a lot of these patients don't do well with these big operations. And I'm going to start with the simple, then work up to the more complex. But basically, what you're looking at on the right side of the screen is an arteriogram. The groin is at the top, and there's supposed to be two arteries there. The pipe that goes to the knee and the profunda, which goes to the muscle. And you can see that one of the pipes is missing. And if you look at the second picture, there's the knee joint replacement at the bottom, but the artery just kind of comes back in just somewhere above the knee. And the typical operation for this is a fempop bypass. You make an incision in the groin, make an incision at the knee, you put a graft through the leg, and it works very well. 5-year patencies are about 80%. The problem is it's an operation, and if the patient has a complication like a wound infection and the graft gets infected, it's a big deal. So is there a way to do it better? And for 25 years, I've worked on what I call the endovascular fempop, where I will go through the artery and basically put the same device made into a stent through that artery to try to get flow to the lower part of the leg. Everybody has a different philosophy on what works best. We can talk to interventional radiology. People do atherectomies, they do balloons, they do all sorts of things. But I have found over the years that this gives the similar patencies to the fempop bypass. And this is an outpatient procedure. The patient comes in, goes home the same day. They're not going to get a wound infection or a graft infection. So let's get a little bit more complicated. What about a patient like this? So this patient has a small abdominal aortic aneurysm. Do you have a pointer?
I don't, but you'll be able to, yeah. Now, sure, there you go. You'll be able to see that.
All right, they have a small abdominal aortic aneurysm here. You can see that, and then you can see that their right iliac going to the groin on the right is open, but there's no artery on the left side. If you look at the second picture, this is where the common femoral artery comes in. Traditionally, these patients would have needed an abdominal incision and a groin incision and a big bypass sewn in here and sewn in there. And it's a big morbid operation. And this can be treated endovascularly. And typically, to get through something like this, they do need to have access in both groins and attack this blockage from both directions. You're not always guaranteed to get through from one direction, but usually with attacking it from both ends, you can get through this, and this can be stented. And surprisingly, this has very good long-term patency, especially if the patients follow up and show up and get surveillance. This patient's gonna have their aneurysm treated later. So we dealt with their claudication symptoms first. All right, let's get a little bit more complicated. This is a 93-year-old patient who happens to be a retired OR RN, and she presented with a non-healing wound on her right ankle. You can see her aorta in the center here is just a rock. It's calcium, calcium, calcium all the way around the artery. And there is calcium inside the aorta. Doing an open operation like this on a 93-year-old is impossible, really. And you can't even sew to this artery. The calcium's so thick in this artery that the needle actually won't go through it. So there are some things that we can do for this. And this is just a picture of her angiogram. I've already done an angioplasty, but you can see that she still has this huge rock here in the aorta. I've already ballooned this with something called a shockwave angioplasty, which is basically lithotripsy from within the artery using a balloon. It works exactly the same way as it does with a kidney stone. It basically pulverizes or fragments the calcium so that the calcium can expand. Calcium, you can balloon it, but it comes right back. It's very rigid. So just with the shockwave angioplasty, we're able to get that open, and this was stented. There is a stent in this area, and there's a stent in this area right here. And this was able to get her some inflow. I had to beg her to come in and get this done. She's a nurse, and you know, she's gonna be fine. So she was definitely at risk of losing her right leg. So this is 2 weeks later. She comes in and she has this in her right groin. So this is her femoral artery. The superficial femoral artery down here is occluded. Let me see if that will play again. And then this artery that you see coming in down here is the profunda. So the artery's basically occluded. Again, the traditional surgery for that is to make a groin incision, open the artery, clean it out, put a patch on the artery to make it bigger. It's a wonderful operation. It works very well, and it has good long-term patencies. In a 93-year-old, not ideal. And if you get a groin wound infection, it's very miserable. And the risk of a groin wound infection in most, like, I don't know if there are any healthy vascular patients, but in a healthy vascular patient, you know, having a 5 to 7% wound infection rate is kind of normal. And so if you get older and more comorbidities, that risk goes up significantly, and the morbidity from that is pretty high. So again, this artery was severely calcified, and just using this thing called a shockwave angioplasty and a drug-coated balloon, we were able to get this artery opened up and flowing well. And by 2 weeks, her ulcer on her ankle was starting to heal. And she was able to get both of these procedures done as outpatient procedures. It didn't knock her down at all. She didn't have to deal with any wound complications. And so technology very nicely has advanced over the years since I've been in practice. And every time I seem to think that there's a little niche in vascular surgery that's missing a device, somebody comes out with it. And so when patients come in to see me and I don't have an option for them, I don't send them away. I say, hey, come back next year, because people come out with devices all the time that answer problems that we didn't have today. And so here, let's get a little bit more complicated here. So this is a 65-year-old female. She's on oxygen 24 hours a day, severe COPD. She can only walk about 10 feet before her legs give out. And this is her aorta, okay? Renal arteries here. There's virtually nothing else. And I'll tell you what she said after the surgery, but basically, I had no option to put this patient to sleep. This is usually an aortal bifemoral bypass. Big abdominal incision, big groin incision, and patients like this really challenge you to go to the next step. Surprisingly, these occlusions can be crossed with an endovascular approach, and these are long angioplasty balloons going in both groins, and I may have come from the arm initially to get down and get through the blockage, which can be very helpful. But able to get that open, that's a bifurcated stent graft that's in this patient's aorta. And this was basically an overnight stay in the hospital. She was done awake. She went home the next day, had no complications, and she came back to the office 2 weeks later, and I won't tell you exactly the words she used, but she said, "Doctor, I have not felt my hoo-ha in 2 years." Change the words. So it's, I never say never, and if the patient cannot have what we consider to be traditional vascular surgery, usually we have an option to offer them. All right, let's talk about EVAR, all these letters. Endovascular aneurysm repair or endovascular aortic repair. So this, we typically do this for aneurysms, and the typical patient, there's an aneurysm in here, and this aorta has already been fixed. There's a stent in it, and you can see the top of the stent is just below the renal arteries, and this works very well in the majority of patients, but the patient has to have a normal part of the aorta below the renal arteries for that stent to sit in the artery and to make a seal. If there's not enough artery for that, traditionally the only option was to be opened and done in an open technique, which again, with our aging population, sometimes is a challenge. So, let me do this first. So, the other thing we see from time to time is iliac aneurysms. So, aorta, aneurysm on the right iliac, and then no aneurysm on the left. In the past, when we would do these by an endovascular way, we would have to occlude this artery down here called the hypogastric artery on the right. So we would put some little coils in it, and we would put some stents through the artery. The problem is that when you occlude that big artery to the pelvis, the patients can get butt claudication because they're not getting enough blood flow to the gluteus area. And so there are some newer devices available that bifurcate all the way down at the bottom, and you can see that we were able to repair this aneurysm and keep that hypogastric artery open down into the pelvis. And so again, this is one of these instances where we used to have to do it one way, but then a company came out with a device that fixes this particular problem. Next. All right, fenestrated EVAR, what does that mean? Well, fenestrated basically means making holes in the graft that we use to repair the aneurysm. So this is a fairly complicated problem. So a patient that has an aneurysm in the visceral segment of the aorta, so involving the celiac, superior mesenteric arteries, renal arteries, this patient traditionally has required a thoracoabdominal incision to repair. So in other words, a big rib incision, a big abdominal incision, opened up like a clamshell, and then all of these vessels have to be clamped, a graft is sewn in there, and then you have to reimplant all of these blood vessels onto that graft. Huge operation. They do a lot of these in Houston. But now we have a way to fix that with an endovascular technique, and we've actually done 3 here in Baxter already in just the last 8 weeks. You can see that there's a graft in this patient. So 20 years ago, they had a traditional EVAR repair, but now they come in with this problem. And so what we can do, so here on the right picture, you can see that there's a stent. There's a device going up through the stent. In the second picture, what you see is that that device has been deployed, and I don't know if you can see these little stents here, but these little stents here are inside of all those visceral vessels. Here's the celiac, maybe the SMA, the right renal, and what we have done here is we have basically put a stent that's covered with fabric into the visceral segment of the aorta, and we have covered all of those blood vessels. So the liver, spleen, bowel, and renals are not getting any blood flow right now. So now what do? So those stents that we placed in those visceral vessels are used as targets. And then this is a laser fiber here. So we use this guide catheter here, and we basically, look at it at a right angle like this, and then we will look at it down the barrel to make sure we're inside the barrel, and basically laser a hole in that stent graft to restore blood flow. And that is the superior mesenteric artery in that picture on the right. So once we lasered through the vessel here, here's the down the barrel view I was telling you about a while ago. Make sure the laser fiber's inside that stent. And then we put a stent graft through that. A stent graft means it's a stent with a fabric coating, and we put it through the graft into the aorta and we flare it. That's what this big balloon is here. And what we're able to do is restore blood flow to that vessel, while at the same time treating the aneurysm, which is what the big stent in this direction is doing. So we just had a patient 2 weeks ago that came in on Wednesday night, 82-year-old female with a ruptured aneurysm, and we were able to do this at midnight, and she went home in 2 days. So that's typically, an 82-year-old would not survive an open rupture repair at all. So it just gives options. Here's just some pictures. This is getting the left renal artery done. Here's the celiac artery. Here's the celiac artery. And what we have when we're done is you see the stent all the way up here in the thoracic aorta, and all of the visceral vessels are open, okay? Most of these patients are in the hospital one night. If you have a thoracoabdominal repair, you're gonna be in the hospital a long time. And then recovery, how long does it take somebody to truly recover from something like that? At 75 years old, maybe never. All right, next, thoracic aneurysm. So we are able to treat descending thoracic aortic aneurysm, sometimes in combination with cardiothoracic surgery. More proximal dissections can be treated. And what do I mean by dissection? You can see that here's the arch, and then there's a tear in the inner lining of the artery, and now there's 2 lumens within the aorta. And one of these is considered the false lumen, and one is the true lumen. Well, this also can be repaired with a stent graft, which is similar to what we do in the abdomen. In this particular one, we had to cover the left subclavian artery, which is not uncommon in this procedure. But again, using this laser and stent fenestration technology, we can come from the arm. Here you see the catheter coming from the left arm, and we've lasered a hole through the graft and put a stent in there. So again, we're able to get further and further and further across the head vessels with this type of technology. All right, next, TCAR. What is TCAR? Carotid, it's transcarotid arterial revascularizations. It's not such a new procedure anymore. And this is actually how I met Dr. Noctegal. He started doing this exactly a year ago. And I came here to proctor him to do his first case. And he did 3 in a row. He did an amazing job. I've watched physicians all over the country operate. I can tell you Dr. Noctegal is the man. He does a great job. And we sat down for coffee and afterwards, and he said, you need to come up here and work in Mountain Home. I said, well, Kent, I'm not looking for a job, you know. He said, you need to look. So here I am. So how does this work? All right, what is a TCAR? So basically we make a small incision just above the collarbone. We put a needle in the artery. We use an x-ray machine basically to guide a wire up through the carotid artery blockage, balloon it, and put a stent. Sounds simple. The key to the procedure, though, is what they're showing right here. We actually put a sheath in the femoral vein, and we connect a catheter or a tubing from the neck to the groin, and that has a filter in it. If you see it right in the center of that tubing, that's a filter. And so we clamp the carotid artery, we clamp the carotid artery to create reversal of flow. So if you just ballooned the carotid artery and put a stent in it, there's gonna be some debris that breaks loose. And distal filters, our little basket up here, have been used for years coming from the groin. The problem is the stroke risk of doing that technique with a distal filter is about around 6%, at least in the major trials. The benefit of this kind of system, and to a lot of people, including me, when I first saw it, I thought this was a step backwards. I'm like, wait, we went from a big incision to a little tiny incision, now we're going to a medium incision? Like, is that a step backwards? But the truth is, I don't know if there's a safer way to do this procedure than this because of this reverse flow. So if we can reverse the flow away from the brain, when we balloon that artery, any particles that break loose will come out and be captured by that filter. And you let that wash out for a couple of minutes, and then when the procedure's done, then you unclamp the artery and let the blood flow go back to the brain. So the genius is in this little piece of tubing that goes from here to here. It's not in what we do up here. And this actually works very well, and surprisingly, the long-term patency of the stent is exactly the same as with an endarterectomy. It's 6% for the rest of your life that you could have a restenosis. So basically 95% of the time an endarterectomy and a stent will be open for life and not need any other intervention. So I think Dr. Noctegal's done 100 cases now, I think that is going very well here. Now, I'm going to show you, I only have about an hour more. I'm going to show you two more procedures. One I've been trained on but have not done one yet, but it's coming. And then the last one is a new technology that's coming as well that we have not done. And I hope to be able to add these at some point in the near future. So, detour procedure. So if you remember the first case I showed you, the fem-pop that was occluded, the long occlusion, well, the challenge of that is getting through that blockage, okay? How do you get through it? Well, if you don't get through it, what's next? Do they immediately go to a fem-pop? Well, this is kind of an answer to that problem. So here's this long blockage here in the SFA, and let's say we've tried to do the traditional, get through the blockage, but we just can't. Most people would go to a fem-pop bypass. Well, this company has developed a system they call Detour. And what they basically do is use this, see this needle on that catheter? They basically puncture from the artery into the common femoral vein. So they'll show that here in just a second. And you have to put a little catheter in the vein at the ankle. So here's the venous side with a little snare. And so what you're seeing here, here's the catheter in the artery, here's the snare in the vein. You puncture a hole into the common femoral vein and then balloon that track. So the detour, right? This is a slow video. It's kind of like watching surgery. So now you basically go all the way down to where the artery is normal, generally around the knee joint. And now you're in the vein, so you're going to puncture into the artery. Again, balloon that track. And then that entire length is going to be stented. So you've now detoured, so it's basically a fempop bypass, except the graft is going through the vein. And I know what you're all thinking. Don't they all get DVTs? You're occluding the vein. Surprisingly, the incidence of DVT with this procedure is about 2%. It's not significantly higher than the average population at this age group. There is some preoperative testing that we have to do to see if the vein is large enough to put the graft in there, so not every patient is a candidate for this. But it's another tool in our tool chest for treating some of these patients. Again, this is becoming outpatient. There was a requirement to be inpatient for a while just for coding and payment purposes, but they're actually starting to approve this as a same-day go-home procedure. All right, next. Distal venous arterialization, what is that? So we see a lot of patients with diabetes, with end-stage renal disease, and their proximal larger arteries are fairly normal. They may be calcified, but they are wide open. But what they develop is small vessel disease. So they get tibial artery disease, and they also get end-stage small vessel disease in the foot, okay? And traditionally, most of those patients, a lot of them, we tried distal bypasses all the way down to like the dorsalis pedis on the top of the foot or the posterior tibial at the ankle, but their problem is outflow. There's nowhere for the blood to flow, so a lot of those grafts fail, and those patients still end up with an amputation. So this is an answer to that problem, and it's called distal venous arterialization. It can be done with an open procedure, but someone has developed an endovascular option. And so what is this? So it basically means instead of sewing the bypass into the artery at the ankle, you sew it into the vein, right? So you're basically creating retrograde flow through the venous system, through the capillaries, for perfusion of the foot. And typically patients with this problem do have more advanced disease like gangrene. So in this particular procedure, we will access a small vein in the bottom of the foot and run a wire up through the vein. It's very similar to the detour procedure, but different company and for a different process. So again, the arteries are typically normal proximally. So you bring this catheter down, and similar to the other procedure, you're going to puncture from the artery to the vein, snare that wire, man, it seems so much faster in the OR. So same process as before, we're just crossing that arteriovenous segment, balloon the tract, and then, now that there's flow into the veins, the problem you have in the veins is that there are valves in the veins. So now you have to pass this valvulotome through the vein to lyse or cut all of the valves so that blood can flow towards the foot, okay? So now that you have antegrade flow in the vein, you put a stent graft through the vein. Oh, that's interesting. When I was copying that video, I got an email.
Could have been worse.
Right? So there you go. So now the venous system is arterialized. And you can save some limbs with this. It's not as good as sewing into the artery or revascularizing the artery, but surprisingly, you can save some limbs. And you know, some of these patients don't have the longest lifespan at this stage of their life. So if you could give them a year or 2 years with their limb, that means a lot to them. So, all right, that's all the stuff I can do. If y'all have any questions, I'm happy to answer them and let y'all get on the rest of your day. All right.